Good morning, good afternoon, everyone. Welcome to the Expert Insights webinar series. Today, we're going to talk about how the ZyMōt multi-sperm separation device can be integrated into IVF laboratory workflows. The idea of this webinar series is to allow us as colleagues to discuss procedures and how those can be used. And it's designed to provide a platform for professionals to share insights and experience, and we'll be drawing on the experience of a particular expert today that we'll introduce in just a moment. Thank you for joining us. If you have a look at your toolbar in Zoom, you'll see a Q&A option, and if you could submit questions via the Q&A, we will address those towards the end of the webinar. We've got a number of questions sent in advance, but we are very keen for you to engage and send your questions during this webinar as well. For those that don't know me, I'm Dave Morroll. I'm Director of Clinical Support at CooperSurgical. I've been in embryology since the mid-1980s, working principally in the UK, and currently I'm working as the Director of Clinical Support at Cooper, involved principally with things like the education, training, and so on. And we're joined today, I'm pleased to say, by Emma Ebinger, who is the Scientific Director for Adora Fertility in Australia. So she's responsible for 4 labs across Australia. She started here in the UK and moved some time ago to Australia, but has worked for over 30 years in embryology, and she's passionate about driving developments in the IVF lab to continuously improve the way the embryology laboratory works. And we'll hear from Emma in just a few moments. I'm just going to give some background into the ZyMōt device, and then Emma, who for the purposes of this webinar is a paid consultant for delivering this lecture, she will give us the real deal, if you like, of how it's used clinically in the lab and how she's introduced it and where the benefits potentially might come from. So the ZyMōt multi-sperm separation device comes in 2 sizes, and it's essentially a system for separating sperm based on their motility. So it depends on motile sperm swimming through pores in a membrane that can be collected. And the evidence that we have from the published literature shows that we get a more reproducible sperm prep at the end than a standard swimmer with better sperm quality. And we'll discuss that in more detail as we go through. So the device is very simple in that there is an inlet and an outlet port, and that provides an upper and a lower chamber. And the sample is introduced in the lower port, in the lower chamber through the inlet port. Medium is placed over the top, on top of the membrane, and then that's simply incubated, and the motile sperm are allowed then to swim through the pores and be harvested from the upper chamber after an incubation period of 30 minutes. And as we'll show you, that has some advantages in terms of the quality of the sperm that is recovered. Now, the important thing about the membrane used is this is well tested. This is data from 11 years ago now, from 2014, from Asghar and colleagues, who looked at membranes with various sized pores in the membrane and looked at how that impacted sperm preparation and the type of sperm that are collected. And very quickly, to summarize this, what they showed was that when you compare different pore sizes, what they found was that you got high motility pretty much regardless of the pore size, which is understandable because this is a motility-based selection device. And what was perhaps more pertinent is that they found that the 8-micron pore size gave the best overall retrieval efficiency. In other words, the number of sperm that you collect at the end relative to the number of sperm that go into the lower chamber. And when we look at the 8-micron size pores in a little bit more detail, what they also were able to demonstrate is that it was the most effective pore size for getting the best proportion of morphologically normal sperm post-preparation. The nuclear maturity was highest with 8-micron pores. And importantly, the DNA fragmentation was lowest when the pore size was 8 microns. So that's where that choice of pore size comes from. And what they also demonstrated was that the peak retrieval efficiency was seen at 30 minutes. In other words, there wasn't any clear benefit of extending the incubation time beyond 30 minutes, which is why that appears in the instructions for use. What does it do? What are the advantages? This is a paper from 2019 by Broussard and colleagues that compares different preparation methods. You'll see here the raw sample, and you'll see density gradient plus swim up. And what they demonstrated really nicely was that compared to the raw sample, density gradients can reduce DNA fragmentation in the post-preparation sample. But the ZyMōt device reduces it really, really significantly. And I hope we're all aware of the potential advantages of limiting DNA fragmentation in our post-preparation sample. That's borne out by other workers. This is Alexandra Parella from Giampiero Palermo's lab in the US, where again they compared ZyMōt with density gradient. And you can see the parameters here. It's motility based, so you get lower numbers of sperm. But the one I wanted to focus on was the DNA fragmentation, which reduced significantly. You got 12.5% levels of DNA fragmentation post density gradient and 1.8% in the ZyMōt preparation. So very significant step down in levels of DNA fragmentation. And that was also shown in this paper from Matezel and colleagues from IVF Brussels, where again they compared ZyMōt with density gradient. They also included MAX, which separates out sperm with apoptotic nuclei, and compared it to a simple wash. And again, just wanted to focus on this line where the most significant reduction in sperm DNA fragmentation was when you do this ZyMōt sperm preparation. Emma Adolfsson published on the use of the ZyMōt for conventional IVF. And this is taken from the paper, just highlighting the fact that ZyMōt, because it's a motility-based separation device, shows a better motility post-preparation than density gradient across a wide range of samples. And these were split samples, so that one half of the sample was done with the ZyMōt and one half was done with a density gradient. So we're selecting sperm based on their motility, but importantly, we know that the motility links to the quality of the sperm and the low DNA fragmentation rates. Does it have an impact on other outcomes? Sorry, not incomes. Does it have an impact on other outcomes? Well, this is data from Godiwala and colleagues, again, a US lab, where they did retrospective and sibling oocyte studies and showed an improvement in fertilization rate after ICSI. Does it work with conventional IVF? Again, coming back to Emma Adolfsson in the Örebro lab in Sweden, they published on conventional IVF. And what they demonstrated was that when they did an initial evaluation where they just looked at a number of cycles, they showed that it worked perfectly well. What was interesting here is that they reported that when they then implemented ZyMōt into standard clinical procedures, they actually noticed a dip in fertilization rate and utilization rate. But as is stated in the instructions for use, when they introduced the post-preparation wash for conventional IVF cases, the fertilization rate and utilization rate returned to what they were expecting to see. We also have this nice paper from Eleftherios Gavril and colleagues published this year, which looked at the use of the ZyMōt for frozen thawed sperm samples. So we know sometimes that can be an issue for motility-based separations like the swim up. And what this paper showed was that with a simple one-to-one dilution of the thawed sperm with medium and underlaying that into the lower chamber of the device, what they were able to show was that they could still generate very nice results. You can see here that the fertilization rate, the cleavage rate were similar to density gradient, whereas they saw some improvement in blastocyst formation. Maria Banti in Dubai published her data, and interestingly here she found no difference in fertilization, but actually demonstrated some improvements in post-fertilization events, so blastocyst formation, utilization rates, and the rate of euploidy. And if we look at the rate of euploidy, this has been linked with sperm DNA damage now in a raft of papers. I've shown some examples here linking DNA fragmentation to aneuploidy or euploidy rates. So we might reasonably expect that if ZyMōt reduces sperm DNA fragmentation, that we might see an improvement in euploidy. And actually, when we look across all of the publications that we have so far compared to density gradient, we see that the ones with an asterisk are the ones where we see statistically significant improvements in euploidy rate. It's not seen in every study, but I think we can say with a reasonable degree of confidence there's a trend towards higher euploidy rates. And I'd particularly point you to the Anderson publication here, which was with significant numbers of sperm and showed a moderate increase, which I think is a particularly good study to look at. Okay, that's enough of me. Now I'm going to hand over to the real expert and ask Emma to talk to you about her practical experience of using ZyMōt in her laboratory, how it impacts workflows and so on. So I'll stop sharing and hand over to Emma.
All right, so thank you very much, Dave. And thank you for this opportunity to share our experience from Adora Fertility in Australia. Okay, there's my disclosure slide. And I guess if we look back in time, there haven't been too many things that have been happening in terms of sperm preparation methods over the years. So we've really only gone from a kind of a wash in the early days to a swim up. Then along came the density gradient centrifugation method, and I think some of us were using some off-label solutions then. Then the media companies got involved and actually gave us IVF quality density gradients, and we've been using those for many, many years. And really, it's only sort of since the 2000s that we started getting some other selection devices, such as Pixie, Sperm Slow, based around the hyaluronan binding. So it's quite exciting where we are now, where there's other options on the market that we can look at. So if we compare that to what's happened across sort of culture, there really hasn't been too much that we've been able to do. And I mean, despite all of that, the actual aim is always really to separate those motile sperm from the seminal plasma, get rid of all of the unwanted components, the epithelial cells, the leukocytes, and the immature germ cells. So I'm just really going to give an overview of our experience from implementing the ZyMōt as a routine sperm preparation method across all of our laboratories. Look at how we did it, staff training, validation, and implementation. So hopefully I'm able to share our experience in the next 15 minutes or so. So just a little bit of background from us. So we've got the 4 labs, and they're 4 very busy labs. We did last year around about 6,000 fresh cycles, and we're probably going to see about a 20% increase this year on those numbers. And the ethos of the business, Adora Fertility, is really to provide accessible IVF treatment for all patients using evidence-based scientific protocols with the aim to minimising the financial burden to our patients. And how we do that is utilising current technology and efficiency in the clinic and the lab flows. Now, I probably don't need to remind the audience here of some of the challenges that we face in the laboratories at the moment. We get variable workload with fixed staff numbers. It would be lovely if we had the same number of pickups every day, but in reality, that never eventuates. We know that recruitment is getting increasingly difficult as cycle numbers increase and the demand for embryologists increase worldwide. We all know that the training of junior and trainee embryologists is very labour intense, but obviously extremely important that it's done well. We've got extreme compliance to legislation and industry standards, and we need to manage risk across every procedure that we do. All of that while, of course, the most important one is maximising the clinical outcomes for every single patient. So when we started to look at these devices, I won't go through all of the science. Dave's done a good job of that. So we were really looking at the scientific evidence needed to be there. So the ZyMōt ticked those boxes. We looked at the design of different devices, the efficacy and the efficiency. Obviously, it needed to be approved for use in Australia, or otherwise that wasn't an option. And so I put together basically benefits, risks, costs, and some of the validation KPIs. And I'll just skip that slide because Dave's already covered most of that. But some of the other rationale around why we chose ZyMōt, as well as all of the scientific evidence, was really that we thought it was something that was going to be very simple to use, something that we could introduce easily, and something that really aligned more with the in vivo model, because obviously the first lot of sperm that swim through, you could propose are the ones that in nature may have reached the egg first, and such that it's maybe more aligned to the natural selection that happens in vivo. Obviously, we wanted to look at how many of our patients ZyMōt would be suitable, and that's around about 90% of our patients. And when would it be suitable to use it? When would we need to change the protocol? So as it's a progressive motility-based device, those are patients with very poor motility and teaser and PISA, although I believe some centres have given it a go. We haven't. So we got all of our embryologists trained in the ZyMōt, and they completed the online training module that Cooper provided, which is a great lab simulation of steps. I've never actually seen anything like it. You actually can move it around. It's like a virtual sperm prep. And each one of our scientists then received a certificate of completion. And we had some samples in the lab to familiarise all the staff with as well. We were able to track the embryologist competency metrics through our lab KPI reporting. So obviously it was important for us to have consistency and to be able to monitor this. So each of those lines is one of our embryologists, and you can see that we've set up our competency at 65% fertilisation, and our benchmark is at 75%. So that's of mature eggs inseminated. So we had that set up already. So we were able to track when we introduced this, how the consistency was playing out, whether there were any issues with staff, or whether there was any retraining required. So we commenced a validation trial, and we compared sperm count motility with the existing density gradient centrifugation method. It was across each of the 4 labs, and they did a minimum of 20 samples. What we found was we saw a very slight reduction, less than 5% in overall final count, but we saw a marked improvement in the motility of the final prep, which was around about 20% greater. We then developed a bit of a matrix for looking at these incubation times, because what we were finding was that we were almost getting too many sperm. It was almost too good after 30 minutes. So we started to look at how we could reduce the need for a dilution step, especially in our ICSI and our processing time. This validation trial allowed everyone to get familiar with the device, and as I said, we were able to track, and we saw less variability between embryologists that were using the ZyMōt than the density gradient method. Okay, so how we did it was all of our males produce on site, and we allow the sample to liquefy for 30 minutes at room temperature. We then perform a semen assessment, and we're looking at count and motility. If we came across a very viscous sample, we added 1/2 ml of sperm media and gave a gentle mix. And we wanted to see that the discrete drops could be formed, and then it was suitable for the ZyMōt. If when we dropped it out of the pipette, it didn't form those discrete drops, then we didn't use it on the ZyMōt. It was too viscous. But with a bit of pipetting, most very viscous samples can be broken down. The cutoff we used for ZyMōt is at least 1 million motile sperm per mil, and only samples with progressive motility. So any of our teaser and PISA and surgical sperms weren't suitable. As Dave said, frozen samples, donor samples are pre-diluted 1:1 before loading onto the device. And once we had collected the final prep, if the sample was not being used for immediate insemination, we stored it at room temperature for about 20 minutes prior to insemination, and then we warmed it up to 37 degrees for insemination. So these are the lab equipment that's required. Some syringes, the actual device, conical tube, a final tube. There's also a Petri dish that we use for the incubation period. So this is how we set it up. First of all, we put on our RFID witness tag, And then on top of that, we put the male and female sticker with the 3 points of ID. So in our clinic, we use full name, date of birth, and UPN, and we sit that in the large Petri dish there, just for handling, and also when we're incubating it, it allows it to have a cover top. And how we do, I think probably I won't go through all the steps because you've seen the little video, but I think there's a few steps that we found that were really, really important, and it was the loading speed. We found that you needed to be quite slow and steady when you were loading the semen into the port. And again, when you were covering the membrane, slow and steady. So not sort of squirting and splashing things, just nice and slow with that. That was something. And again, following the incubation step, when you're taking off the final prep, it's to go nice and slow and steady again, just so that you don't create any kind of vortexes with the fluid. So how we do it is that we take off 500 microliters from the final port for ICSI. And for IVF, we then add 3 mils of sperm media and give a 5-minute wash step at 300 G. So I guess what this slide shows is that the fewer steps that are involved in using the ZyMōt. So you can go from like 4 or 5 steps, depending how many washes that you currently do, down to 3 or 4 steps. So what we did find was that the overall preparation time was very similar. If you took from start to finish, that's very similar. However, the difference we found when we did a time and motion study was that the hands-on time in the critical work area inside the crib was reduced to 5 minutes. So that allowed, because most of the time the actual incubation time is in the incubator. So the actual critical work area is cleared, and then it can be cleaned and used for another sample. So in our time and motion study, we were able to process an additional 25% samples using the same lab resources once we switched to ZyMōt. Another advantage is that often samples all arrive at once. This allowed us to get those samples to be processed within the optimal time of 1 hour of post-production as well. Okay, so following the validation study, we implemented the ZyMōt as a routine method for all suitable semen samples in July 2023. And as I said previously, this works out to be around about 90% of our semen preps. So I'm just going to give a few slides of our results that we've seen since that time. So this is really a consecutive unselected patient group. So we just compared when we were using the density gradient to when we were using the ZyMōt. And what we can see here is that we were looking at the differences between those groups, and we performed a non-inferiority analysis looking at the samples that were performed with ZyMōt compared to density gradient. Obviously, female age is a confounding factor. And so when we were able to control for that, our fertilization rates with IVF and ICSI with the ZyMōt are just, I don't know if you can see my cursor here. And for the density gradient, the fertilization rates were broken down between ICSI and IVF there. And what we were able to show that there was no inferiority of ZyMōt in embryo utilization and pregnancy rates. And that's just summarized in this slide here. So you can see there. Once we did adjust for the confounding factor of female age, we did actually find a significant difference between the fertilization rates. And currently we're collating all of the live birth data to review this in a bit more detail, but this was certainly very reassuring for us. So I guess in conclusion, the use of the sperm separation device, the ZyMōt, and we used the 850 microliter model on fresh semen in an unselected patient population has led to higher fertilization rates in IVF and ICSI cases compared to our previous method, which was the discontinuous gradient separation. We're just going to take this a bit further because, as I mentioned before, we feel like 30 minutes gives us too many sperm in some cases. So we're actually found that in a bit of a pilot study that around about 5 to 10 minutes incubation may be sufficient, especially for ICSI cases when you've got at least 500,000 motile sperm per mil. And this is reducing the requirement for an additional dilution step. So we're currently doing a bit of a study to see what parameters would work best and seeing if we can reduce that time. I mean, obviously that's outside of the recommendations that Cooper made, but we feel that our results indicate that this would be wise in the cases of ICSIs. So the effect it's had on our workflow in our labs, we can do more samples can be processed within the same time frame, and we've seen around about 25% more. They can be prepared within the optimal time frame. There's fewer steps involved, allowing the critical work area to be cleared during the incubation time. There's fewer steps in the process, so that equals less witnessing or RFID tags, which saves time, cost, and reduces risk. And the feedback from the embryologists has been extremely positive, which is one of the most important things. So I guess sort of take-home message from our experience is that it's easy to use, fewer steps, you can save time witnessing, fewer steps in the chain of custody, which reduces the risk. It's simple to train new scientists. The results are reproducible and consistent. And some scientists did comment that the ICSI samples are cleaner, and so they've required less injection pipette changes since these have been introduced. And it certainly improves the lab workflow efficiency. I'd just like to acknowledge Andy Tan, lab manager in Perth, who's helped with this study. And I'll leave this slide here to add to what Dave said around the workflow, the handling steps, time saving, along with all the clinical evidence that he's presented. Thank you very much. There's some references. Thank you.
Thanks, Emma. Let me get my camera back on if you really want to look at me. Right, let me just share my screen again and we'll just start to do some Q&As. Can you see that okay? Okay. Thanks, Emma. That's really helpful, and I think it's a really nice way of explaining how the device is used practically, because it's okay for us to talk about the studies, but actually people want to know what it looks and feels like in the lab itself. Right, we've got some questions. Let's work through some of these. I won't necessarily do them in the order that we've got them. First, first one perhaps we can deal with is what was the reason for introducing the 5-minute wash step for IVF samples? Or rather, why was there a reduced fertilization rate if the sample was not washed? Um, shall I give the official answer, Emma, and then perhaps you just chip in with your experience of it? Um, what in the earlier days of the use of ZyMOt, so before CooperSurgical acquired ZyMOt, there were a small number of reports of poor fertilization rate, and that instigated an internal study. And the internal study was done by appointed external consultants that, together with some experts from universities in Canada and the US, looked at possible causes and concluded that there might be seminal plasma factors being dragged up through the pores with the sperm that contribute, in some cases, to poorer fertilization rates. They then recommended a wash step as a potential remedy and then tested that in some customer labs and showed that the fertilization rates were as expected after a wash step, and that was introduced into the official instructions for use. So that's the sort of background to it. That's why it's there. But Emmy, your fertilization rates for conventional IVF were really fine, weren't they? But you do a wash step.
We do a wash step. I'd read the paper, and yeah, so we don't have any experience from not doing the wash step, and based on that research that you've spoken about.
Yeah, it's a strong recommendation. Let's put it that way.
I wonder if with a shorter incubation period we'd need it, but I don't know if I'm certainly not going to start changing
Oh, well,
the recommendation.
let's deal with that one, because that's really interesting. It's one of the questions that we've had was around whether the incubation period would have an impact. So we received a question in advance of the webinar about whether the protocol can be modified, and specifically whether incubation time can be reduced and whether that would impact. But you're testing that, aren't you? I should say that the
Yeah.
official IFU says 30 minutes, but you're testing that.
Yeah, because what we were finding was we were having to do a dilution step, which kind of took away some of the advantages of the process and the efficiency. So we're really looking at it for our ICSI patients where we've got good motility, and we do believe that 30 minutes may be too long, especially when you've got you're only looking for a few good motile sperm in most cases, and we feel that probably around 5 to 10 minutes is enough if you've got normal motility, even in very low numbers down to like 0.5 million motile per mil. So we're currently doing a study to basically come up with a matrix to define the parameters and the timeframes.
Yeah,
hopefully next time I'll be able to speak a bit more on that.
Yeah,
but we're certainly not applying that. We're not at this stage applying that to our IVF cases.
Okay. And what about longer incubation times?
We haven't gone longer because we don't see that there would be any advantage to
You don't see
going
any
longer.
value.
No, there wouldn't be any value.
And in terms of IUI samples, where you perhaps want to get this balance between numbers and volume, do you still use the 850 device? Would you use the 3 mil device?
Yeah, we generally don't do, to be honest, we don't do a lot of IUIs. We've got both, and we would look at the sample and see, because obviously we want to maximize the insemination count of motile sperm. So we kind of adjust it depending on the volume produced and the semen parameters. So if you had a very we probably use more 3 mils to answer that question, yeah, that we would use for IUIs.
Okay, and then if you're taking the sample off the 3 ml device for IUI, would you spin it down to concentrate them before you inseminate, reduce the volume, or do you just use as it comes off?
We'd use as it comes off.
Okay, okay, interesting. Okay.
Mm.
And just for clarity, just because there are questions coming through in the Q&A, you don't do the wash depth for standard ICSI
No.
inseminations. It's purely
No.
for the conventional IVFs.
Mm.
There is a question, again, we'll stick with IVF preps just for a moment. Have you encountered any contamination with ZyMōt prepared samples for IVF preps?
No. Since doing in 2023, we have had one contamination that was linked back to a male infection, but it was limited to one patient. Like I say, we were able to treat. He was treated with antibiotics and came through again. He was fine. So we haven't seen any increases in infection in our cultures as a result of this. No.
No, and I guess that's no more likely than a standard swim
No.
up, is it really?
No.
Okay. The follow-up question for that was whether people have compared DNA fragmentation post-preparation for ZyMōt IVF samples with and without the spin step, and perhaps I can answer that one. That was done as an internal study. I mentioned that the external experts that looked at the poor fertilization rates when they advised on the introduction of a wash depth, they did exactly this. They looked at the DNA fragmentation with and without a 300G 5-minute wash depth and showed absolutely no impact on the level of DNA fragmentation with and without the wash. So I think as long as it's short and gentle, I think we can assume that has no great impact. Okay. Right, I'm just scanning the questions. What about combining ZyMōt prep with other methods? Like you mentioned PICSI and sperm slow, where you use the hyaluronan selection of sperm prior to injection. Have you ever used the two in combination? Do you perceive there might be an advantage, or?
In my opinion, I wouldn't feel that would be necessary, given the scientific evidence that you presented. However, I haven't got any personal experience of that.
No, and I think from memory, I'm not aware of any studies doing that. All I would say is that the ZyMōt is designed to select a prepared population of sperm with low DNA fragmentation, whereas PICSI and sperm slow, for example, are designed to allow you to pick that one sperm that you're injecting. So you may choose one or the other, or you might feel that they're complementary, but at the moment we don't have data to back that up either way. What about I'm just again scanning questions, but there's a question about morphology after density gradient against ZyMōt and whether you've looked extensively at the morphology.
We haven't in a scientific study, so it's just anecdotal kind of observations, and we certainly have noticed that it does appear to be similar or better than a density gradient preparation, but we haven't done any staining or any formal studies on that.
Okay. Morphology is always a bit of a tricky one, isn't it? When unless you count lots and lots of sperm. But what I can say in response to that question as well is that I sort of went through it quickly because I wanted to spend more time seeing what your discussion of things, Emma. But the original ASGAR paper that looked at this showed that the morphology was better with the 8-micron pores. And there are a couple of studies, the Perella and the Matazal one that I showed, that report morphology, and it is better in the ZyMōt than a density gradient. But I sort of whizzed over that, and I wanted to focus on the sperm DNA fragmentation. So you can go back to those papers, and that will show an improvement.
I guess the thing that we're really interested in seeing, and just waiting for all the pregnancy data, is really those older patients where the eggs are losing their ability to repair the DNA fragmentation, and maybe we do see, you know, better ongoing pregnancy rates and maybe even better live birth rates. So they're the population of patients that I'm really interested to look at following the introduction of ZyMōt, because if you think about it, that they may be like a subgroup that benefit more than, say, your younger patients with this preparation method.
Yeah, I'm hoping you'll come up with all that data for us, Emma. Just on that point, it makes sense, doesn't it, that we know that sperm DNA fragmentation is linked to miscarriage in particular, and we know that the oocytes of good quality oocytes, typically of younger women, can repair some sperm DNA fragmentation, whereas poor quality oocytes, predominantly from older women, are less able to do that. So the age impact of the female partner on the outcomes using ZyMōt compared to other methods might be a really important factor. It's worth considering. If you don't use it for everyone, it might be most beneficial for older patients, I guess.
Yeah, I think also, I mean, we were hoping that this would be of equivalence, like, but we have seen benefit, because obviously we don't want to introduce something that's new and making the lab nice and efficient and making the embryologist happy if it's not improving our clinical outcomes. So we're really happy. We feel like it's ticking both boxes, which is great.
So which was the primary driver when you introduced it? Was it the lab efficiency or potential clinical benefits, or do you always look at both, I guess?
Well, I always look at both, but and they don't always go hand in hand, do they? When there's new things out, sometimes it's more labor intense. I think I like the simplicity of it. That was the very first thing that like triggered my interest, to be honest, like how simple it was and how standardized it was. And obviously, so it wasn't one thing or the other, it was everything in combination. But like, I remember seeing it, I think I saw it about 2022, and I was just like, oh, wow, is that it? Like, that's great. I want one.
Yeah, it is certainly simple.
I think I stole the demo, yeah.
Yeah. A really practical question has come in, Emma, which I'd be interested to get your view on. If you've got a sample of low volume and you add medium to it to boost it up to the full 850, should you use the same medium as the one you're putting in the upper chamber, or does it make no difference?
We do, yes. We use the sperm wash media. We do,
okay.
Yes.
And this, when you say sperm wash medium, this is a Heapies buffered wash medium, presumably. You haven't tried it with a bicarbonate buffered medium and put it in a gas incubator, because I mean, I'm assuming that would work just as well.
Yeah, I would imagine so, but no, we haven't tried that.
You haven't tried that? Okay.
No, I think I could imagine that in theory would work just as well.
Yeah. There's another question around the incubation. Is it ambient atmosphere or with gas? And I guess that's dependent on the medium you use.
Yeah. We do it at 37. Yeah. But I do wonder whether that is necessary, but we're following the IFU that was provided. So it's also nice to have for our incubator has a separate section, so we were able to put one of the devices in each section, so that works well in terms of a risk minimization as well, so that they're not all sort of sitting on a bench together or all on a shelf together.
Understood. Yeah. And it might be, I think just to be absolutely clear, if you're using your HEPEs or MOPS buffered medium, it should be ambient gas atmosphere. If you're using a bicarbonate buffered medium, then you would typically use your CO2
Yeah.
enriched incubator.
Yeah.
We've sort of dealt with incubation times, incubation temperature. At the moment, all the data that I've seen is for incubation at 37 degrees. It may well be possible to do it at other temperatures. We know swim ups were done at 30 degrees or even room temperature,
Mm.
but we have no data on that, and it wouldn't fit with the IFU at the moment, at least.
Mm. Mm.
There are a few questions around the sort of cases we can deal with, and I just want to be absolutely clear that there's a few questions around PISA samples and the
Mm.
HIV discordant couples. You're shaking your head.
Yeah, definitely none of the teaser, PISA, micro teaser. No, we haven't used it for those because the motility is usually too poor. Like I say, I have heard reports of people doing it, but like I I certainly wouldn't recommend it based on our experience. In terms of the HIV, I can't comment. I mean, this device isn't designed to screen out viruses and that type of thing. So I wouldn't be able to comment on that. Certainly wouldn't expect it to replace any sort of screening and looking at viral loads before taking on these patients.
Yeah,
That's my
yeah,
my
absolutely agree. And I
advice.
think at
Yeah.
the moment, with the absence of any data to back it up, I
Mm.
would always steer people towards the established methods of density gradient and swimmer that's
Mm.
reported in the literature. So it
Yeah.
may work, but we have absolutely no
Yeah.
literature. So I would steer people away from it
Mm.
um, for those uh, sort of cases.
Dave,
Um,
there's a question saying, why is there no lid?
yeah, why is there no
So
lid?
maybe
Why is there no lid,
so
Emma?
why is there no lid? Oh, well, I guess how we work with that is we sit it in a petri dish, and then it also allows there to be it's easier to move around undisturbed, and also you can then sort of put the lid of the petri dish on, and it covers it nicely. It sort of also creates a little bit of a microenvironment so that it doesn't dry out or anything like that. So I would always recommend sticking it inside one of the petri dishes.
Yeah, and the device is what the device is. It's how it was set up
Mm.
approved for use. So we can't just slap a lid on top. So the petri dish at the moment
Acts as a lid.
is the yeah
Mm.
is the effective way of just controlling conditions around it.
Mm.
Just scanning through some more of the questions. Just bear with me. Oh, what about MAR positive? What about sperm antibodies? I thought,
Antibodies. I think it very much depends where they are and how they're impacting the motility. So if you've got agglutination everywhere, I and they're not swimming freely at all, I wouldn't suggest putting it on ZyMōt. Whereas if you've got good motility in some of your sperm and there's a high density of them, then I would say, again, it will depend whether you're doing IUI, IVF, or ICSI. So you kind of have to look at it a little bit case by case. I probably with the antibody positive cases. Yeah.
it's ultimately it's the degree of motility that dictates whether you can
Mm.
do it,
Mm.
whether the low motility is genuine
Mm.
asthenospermia or agglutination due to sperm antibodies. It's
Yeah.
the motility that's a critical factor, isn't it?
Mm.
The antibodies
Mm.
are almost incidental, I think. Okay,
Yeah.
I'm getting some warnings that we're at the end of our time because I think we could probably carry on for quite a bit longer.
Yeah.
So thank you, Emma, for answering all of those questions. Um, if for any reason you have colleagues that um, were not able to attend, just be aware that um, this has been recorded. We've got the Expert Insights webinars are available online in our Knowledge Hub. I can see there are other questions that we've not been able to get to. So if you need answers to those, please do get in contact with us and we'll endeavour to help with that. And finally, I'd just like to say again, Emma, thank you so much for your insight. It's really helpful, I think, to have someone's real world use of the device being explained, and I think people out there will find that really helpful. So thank you to you, thank you to everyone who's attended this webinar on the ZyMōt multi device, and hopefully we will see you on November the 19th for the next webinar.